and Professor Anthony Gershlick, who's hastening here from Leicester. We'll get him here, hopefully, within the hour. As I say, I'm an old boy. The photograph of me is such as will keep my children endlessly amused. The reference to Birmingham Crown Court is wrong, but apart from that, all is good. Health and safety, be careful out there. As far as progress is concerned, we're going to start with Adam Weitzman, Queen's Counsel. Adam took silk last year. He is described in the various journals as fearless, innovative, astute, and fearless again. He specializes in clinical negligence, personal injury, and abuse cases. He's going to tell us about liabilities for the actions of others. The slides include, I notice, reference to a case called NA and Nottinghamshire County Council, which is due into the Supreme Court next week, which is being argued there, which is all about liabilities for others. I dare Adam to mention another case called JB and Leicestershire County Council. Adam.
I do intend to. Thank you for your introduction, Nigel. As His Honour's indicated, not only do I do clinical negligence, but I do lots of abuse work. And abuse work, however distasteful, is what's developed the law of tort, certainly so far as duties are concerned, in the last 3 or 4 years. And particularly because you are dealing with people who are normally part of an institution but not an employee. For example, a scoutmaster, a Catholic priest, even in my experience cases I've done, a Jehovah's Witness minister. The courts have had to develop the law of tort to cover their liabilities even though they're not employees. And so 2 concepts of no-fault liability. First, vicarious liability, and second, non-delegable duties, have been expanded to cover situations which previously there wouldn't have been liability for on the institution. And this is relevant how to clinical negligence. The answer is, in my view, and certainly in some of the cases I am doing and seeing, we are moving away from provision from the NHS to provision by private contractors. And quite often you think, well, I'll just sue the doctor who made a mess of it. But my experience increasingly is that the doctor who made a mess of it doesn't have cover. There are a number of reasons for that. On occasions, they're not a British national and they've gone, and you can't trace them. Alternatively, they may be with the MPS or MDU, but they have some issue of misconduct earlier on, and those institutions are refusing to indemnify. Thirdly, I am seeing cases where they aren't going to the MPS or MDU, they're going to private insurers, and I don't think there is any guidance as to the level of cover they should have. And so what's available from the insurer won't meet the liabilities. So if you're not suing the surgeon themselves, and it's a private practitioner, who can you go after? Well, I would suggest that you can draw an analogy between the abuse cases, and just as you might go after the Scout Association for the abuse by the Scout Master, so you may be able to go after the private hospital, the private company, who have been the umbrella by which your client, the patient, has had the private treatment. So what I want to do is have a look at the way the law has developed for no-fault liability and then apply it to a case study which I did involving a private hospital where they did pay up for their doctor who'd gone to Karachi and was uninsured. So let's consider first of all the scope of increased private treatment. Under the Health and Social Care Act, Andrew Lansley's Act, we've got clinical commissioning groups seeking private treatment. We've got services being put out to tender competitively under Section 75. Now, that's private treatment for NHS patients, which one should distinguish from the increase in private permission provision which we're seeing with people who've got policies, health insurance. So I'm often finding that people who go to the private sector through Bupa or other health insurers are actually having much worse treatment than they get on the NHS. And in those circumstances, quite often, the consultant isn't good for the money. And finally, you've got private medical provision for treatment, which isn't provided by the NHS. Classically, examples being cosmetic surgery. And if any of you have much involvement in that, it really is the Wild West of private surgery. I was wondering whether we should add 4, which is the trade deal that Teresa's going to do with Donald, opening up to the American healthcare system. Having gone through the English healthcare system, I'm not sure we're not there already, and I'll explain why I say that as we go on. So we need to think about duties, and in some sense in clinical negligence, when we're pleading against the trust, the nature of the duties, the nature of liability doesn't actually ever bother us. We just say, you, the trust, are liable for your staff, and that's a direct duty, a personal duty for the trust, and they can get it wrong in one of 2 ways. They can be incompetent in their selection of their medical staff, or maybe they don't have a scanner or a proper procedure, but more usually it's because the staff themselves are negligent and they are exercising that direct and personal duty on behalf of the trust. An alternative way of putting it, which we don't think about, but is that the trust is vicariously liable for its employees. So rather than saying the surgeon has breached the duty of the trust, its personal duty to provide reasonable care, you can say instead that the trust, because it employs the surgeon, is liable without fault for his or her negligence. Those 2 are in every pleading, particularly as a claim. You don't need to, as it were, break it down because it's also self-evident, or was. What about if we are talking about an institution for a medical liability for a medical professional who's not an employee, so maybe an independent contractor? There are 2 potential routes. One is vicarious liability for those who aren't employees. So what you're saying is, even though you didn't employ the surgeon, his relationship with you is such that you are still liable for his negligence or even for his assault. So for example, we all know there are cases where doctors have committed either assaults in the technical sense, hospital treatment without consent, but sexual assaults, then the trust would be vicariously liable for them, even if they're not employees, if certain legal tests are satisfied. The alternative to that is non-delegable duties. These have only really come into existence in this sphere since Woodland in 2014, in which I was on the losing side, having stupidly decided to deny the duty and take it as a preliminary issue, something we also came in for stick from Lord Sumption for. But a non-delegable duty can be distinguished from a vicarious liability because a non-delegable duty is not the institution's liability for someone else's fault, it's that someone else has breached the institution's duty. That seems a bit odd. But what you're talking about is you have a duty not only to take care, but ensure care is taken. So you can't delegate your duty to a third party. If you do and they breach it, then you are liable even though you didn't provide the treatment. And in some senses, these 2 legal doctrines are complementary. And by that I mean, absent a relationship with employment, I suspect, although there isn't yet case law on it, vicarious liability and non-delegable duties are mutually exclusive. So you won't be vicariously liable as an institution for someone who is truly an independent contractor. But you may owe a non-delegable duty for an independent contractor. And one can think of it in this way. Vicarious liability to legal tests are all about the relationship between the institution and the tortfeasor, the person who's committed the negligent act. Non-delegable duties, the test, is all about the relationship between the institution and the patient who will be the claimant. And so in that way, the 2 are complementary. And in Woodland, Lord Sumption sets out the difference between the 2 at the start of his judgment, because the point about Woodland was there was no vicarious liability. So where a defendant is vicariously liable for a tort of another, he commits no tort himself and may not even owe the relevant duty, but is held liable as a matter of public policy for the tort of another. But it is never extended to the negligence of those who are truly independent contractors. Non-delegable duty, the law does not in the ordinary cause impose personal as opposed to vicarious liability for what others fail to do. The expression non-delegable duty has become the conventional way of describing those cases in which the ordinary principle is displaced and the duty extends beyond the careful to procuring careful performance of work delegated to others. So if you have got an independent contractor and you satisfy the Woodland test, which we will come on to, even though you're not in a relationship of employment or akin to employment with them, you may be liable for their faults because you are asking them to exercise care on your behalf, which you are not allowed to delegate to a third party. So, historically, as I say, this was a problem prior to the 1977 National Health Service Act, and there were 3 cases, Gold, Cassidy and Rowe, in which both vicarious liability and non-delegable duties were considered without much clarity between the 2 concepts. And it ended up that there was vicarious liability for surgeons, even though the hospital couldn't tell them how to perform the operation. But Denning, being Denning, of course, said, no, it's not because there's vicarious liability, it's because there's a non-delegable duty. But as I say, all that disappeared with the National Health Service Act 1977, which said that the health authority, or the trust as it then became, were responsible for all the medical provision provided by those they employed. And because everyone had treatment on the NHS, it wasn't a problem, and we stopped having to think about duties of care in clinical negligence cases. No longer following Andrew Lansley, and now we have lots of private contractors, and they are covered by the NHS Clinical Negligence Scheme Regulations 2015, which sounds entirely tedious, but is slightly surreal. So it's worth having a look at them themselves, but the important regulation is Regulation 10, which I believe is in the back of your handouts, and I'm going to ask you to look at it. Relevant function means arranging services for the purpose of health service. Relevant health service is health service provided in England, but not by a primary care, IGP. Clinical commissioning groups are members of the scheme. Should say Regulation 8 identifies liabilities as injuries, personal injuries caused by a person who's providing a health service. And then we go on to Regulation 10, and it really is worth looking at this because it appears to me, and anyone can tell me if they think I'm wrong, that the effect of the 2012 Act is that we have privatised the profit while nationalising the risk. And that's why I say that we may not need Donald Trump to do it. We've already done it to ourselves. So if you look at Regulation 10, 1, the health provider is an NHS, foundation, other similar body. 2, the scheme applies, has everyone got it, to the qualifying liabilities of a health service provider, the subcontractor, where its provision of relevant health services is the subject of an arrangement between it and another health service provider and an arrangement between a commissioning body, i.e. anyone who's providing a health service for an NHS patient is covered by this. Look at paragraph, 3, but most importantly 7. The act or omission referred to in paragraph 6b, which is the negligence, is an act or omission to act in connection with the provision of relevant health services on the part of A, the subcontractor, B, a person employed or engaged by the subcontractor, or C, an employee or agent of a person engaged by the subcontractor. So basically we can now shift NHS services right down the line, down a contractual chain, and the NHS is bound to pick up the liability. So I give you an example. I have a case, and this is now common in London, where if your GP says you need a scan, you go to something where called in-health diagnostics. And in-health diagnostics have a machine, and they take a scan, and then they send it to someone called Fourways, because they have a contract with Fourways, and Fourways arranges for the scan to be read. And Fourways has a contract with an independent radiologist who is, in the case I was doing, was a Pakistani radiologist from Karachi. And he looked at my client's scan and said, you've got a degenerative problem at the bottom of your lumbar spine. Sent it back to the GP. In fact, she had a tumour which was growing and ate away the bottom of her lumbar spine before she started to bleed rectally when they sent her to A&E and they did a scan and saw what was the problem. So we said to, initially, until we found these regulations, the NHS was refusing to pick it up. So we said to InHealth, you're liable, nothing to do with us. And we said to Fullways, you're liable. And they said, nothing to do with us. The person you need to sue is the radiologist, because he was an independent contractor. He wasn't employed by us, so we're not liable for his negligence. And of course, where is he? We don't know. He's gone back to Karachi. And they had a contract with him, and they were paying him on a piece rate basis. So they say it's £4.50 for a CT and £10 for an MRI, and we'd like you to do 20 a day, and you have to use our equipment. I'm going to come on to the tests which make people liable for independent contractors, all those who are in a situation akin to employment. But we pleaded a case against Fullways on the basis of both vicarious liability and non-delegable duty, and I'm absolutely confident that if the NHS hadn't then, or the NHSLA hadn't then picked it up, we would have succeeded in making the private contractor liable for their independent contractor or quasi-employee. And what was interesting is the defence came back from them saying non-delegable duties only apply to public bodies, they don't apply to private companies. So the concepts are badly understood because that is just rubbish. All right. So that summarises where we are with NHS claims. You can go through the regulations. It doesn't apply to GPs. And while it provides for cover, it doesn't mean that they have to accept legal responsibility. So 3 recent cases on no-fault liability. Cox and Mohammed deal with vicarious liability stage 1 and 2. NA versus Nottingham, which is, as His Honour Judge Godsmark, I'm upset now because he was telling me a case about a litigant in person called him Nigel and had to be corrected, is in the Supreme Court, and it deals with both these concepts, and I hope will define the relationship between the two. So let's start with vicarious liability. And in fact, we have to go back to a case called Various Claimants, where Lord Phillips in the Supreme Court said the law of vicarious liability is on the move, and then Lord Reed in Cox said it's not yet come to a stop, but we can have a look at where it's got to so far. Now, Various Claimants involve the Christian Brothers, who have today or yesterday, through the Irish investigation, come into a lot of stick for the way that they ran homes in Ireland. They're also known as the De La Salle Brotherhood, and they ran a school in Manchester where the brothers taught as employees of the governors of the school, and they were sexually abusing children in their care, or rather the headmaster was, and he was convicted of it. And the claimants sued the governors, and the governor said, well, the De La Salle Brotherhood is responsible for its lay brothers who taught at the school as well, vicariously, because they didn't employ them. And they said, oh no, we're not. We don't employ them. In fact, you, the school, pay them and they give the money to us. So there's no real connection that could be described as an employee-employee relationship. All we do is place them in the school to teach. And Lord Phillips said, let's look at what the test is for employment. He said, 1, will the employer be able to compensate because they have deep pockets or insured? 2, is the tort committed by the employee one where he's undertaking activity on behalf of the employer? 3, is the employee's activity part of the business activity of the employer? 4, did the employer, by engaging the employee to carry out the task, create the risk that materialised, in that case the abuse of the pupils? And finally, was there any control? And he said that those were the elements in an employment contract, but at paragraph 47, if those elements are there absent employment, there will be a relationship akin to employment, and so vicarious liability will apply. So let's forget A for a second and then consider from the point of view of the Christian Brothers. The tort was committed undertaking an activity on behalf of the employer. Now the Christian Brothers' whole purpose was to provide a Christian education. So when they were in the school teaching the pupils, they were undoubtedly acting on behalf of the order. And so also it was part of the business activity or the purpose of the De La Salle order. And they placed the Christian Brothers in the school, gave children into their care and custody, and by doing so created the risk of abuse. And finally, although there wasn't an employment relationship, the Christian Brothers were bound to the order by vows and so clearly under its control. Now that is looking at the vicarious liability concept in a non-business sphere. But you can start seeing that if you've got a private hospital with independent consultants working there, there may be aspects of the independent consultants which fulfill some of these tests on a commercial basis. Two-stage test, as I say. The first is to consider the relationship of the defendant and the tortfeasor, see it's one that can give rise to vicarious liability. And then the second test is to look at the link between the act or omission and that relationship. So in abuse, if you put someone in charge of children, or if you're the Catholic Church and you give someone the power to evangelize, or if you're the Scouts and you get them to take them across the Brecon Beacons, all of those create the risk which materializes, and because you've put them in that position, even if they're not employees, the synthesis of the two stages, the creation of the risk that materialize will be achieved. So then that was applied in Cox, which was a case against the Ministry of Justice by an employee in a prison. And she was in charge of the kitchens, and one of the prisoners working there dropped a sack of rice on her back, injuring her. Prisoners are required to work in prisons, and the Ministry of Justice saves money by using them to work, and they get a very small amount. But the Ministry of Justice said, how can it possibly be said that we employ a prisoner? They are there as a result of their crimes, they are in prison, and they are subject to prison rules, but it can't possibly be employment, and so we're not liable. The claim failed at first instance, succeeded in the Court of Appeal. Ministry of Justice appealed to the Supreme Court. And there Lord Reed, who gave the judgment in this case, and this case has to be read with a case called Muhammad, which we're going to come to, considered the test from various claimants. He discarded one and said, insurance isn't important because you're insured because you're liable. You're not liable because you're insured. He says control is unlikely to be of importance unless it is completely absent, which would be an indication that there isn't vicarious liability. But control isn't relevant because modern workplaces, and you only need to think of Uber. So if an Uber driver negligently crashes it and for some reason he's not insured, could you sue Uber? And it seems to me that if you think about the relationship in the recent employment case, the answer must be yes. So coming back to Cox, control isn't important. What is important is the extent to which the tortfeasor, the Uber driver, whoever it is, the private surgeon, is integrated into your organization. Integrated in a religious organization because he furthers your faith, in a private hospital because he has a business relationship with you, and that's how you generate your profits. So Reed, having got rid of control and got rid of insurance or deep pockets, has a three-stage test before he gets to the synthesis. You need to identify the activity that gives rise to the harm or opportunity for the wrongful act. Is that integral to the defendant's business activity? Is that activity performed for the defendant's benefit, financial or otherwise, by the tortfeasor? And does the activity, this is the synthesis, give rise to the risk that materialized and so caused harm? So that's where we are now on vicarious liability, what I've called stage one, which is there a relationship between the institution and the tortfeasor, the private surgeon, which, while not a relationship with employment, is close enough, is sufficiently integrated for it to be fair to make the institution liable for the negligent or tortious acts. And in Cox, yes, the prison was, and Lord Reed provided the justification in this way. By focusing upon the business activities carried on by the defendant and their attendant risks, it directs attention to the issues which are likely to be relevant in the context of modern workplaces, where workers may in reality be part of the workforce of an organisation without having a contract of employment with it, and also reflects prevailing ideas about the responsibility of business for the risks which are created by their activities. So go back to the example I dealt with earlier of Fourways and the radiographer who'd gone back to Karachi. The reality is, isn't it, is the whole of Fourways' business activity is premised on the basis that they have these people coming in to read the scans. That's how they make their profit. They have contracts which tightly control how they do that. They require them to use their scanning equipment to read the scans, and they supply the scans. So yes, they have a contract which says you're an independent contractor. You have your own insurance, and that's why negligence is dealt with. But at the same time, you can see that they are clearly integrated into their business activity. In fact, if you took those independent radiographers away, Fourways would have no business whatsoever. Stage 2 of the vicarious liability test. So once you've found that someone is close enough to the quasi-employer, is what they did something which is a result of the risk created. And this, again, not close to clinical negligence, but it shows how wide the scope is. So Mohammed went to a service station run by Morrison's, and he asked the bloke at the kiosk if he could print out a map from his, he had a memory stick. And rather than agree to print out his map, an argument develops. Khan, who's in charge, attacked him in the kiosk, then followed him back to his car and assaulted him by punching him through the window and then opening the door, dragging him out and kicking him. And that was despite Khan's supervisor trying to intervene. Trial judge and the Court of Appeal said, well, this has got nothing to do with him running the kiosk. But the Supreme Court said no, it was closely connected to Khan's employment, which involves serving and helping customers. So you might think dragging someone from a car and giving them a kicking isn't really serving and helping a customer. But the reality is, although it's an improper, a completely wrong way of doing what you're employed to do, it is still something which arises from the role you're given. It's a risk created. And so again, looking at the position of a private consultant, it's hard to see for what they would not be liable once they enter into a relationship with a patient if they're put in that position through a private hospital. Okay. As I say, Supreme Court allowed the appeal. So where have we got to with vicarious liability? Employment isn't any longer the test. It's the question of whether the tortfeasor is integrated into the defendant organisation. It will cover volunteers. It will cover those who generate profits unless truly independent contractors for the defendant, and if they are providing benefit in other ways. So the two exceptions may be A, if the tortfeasor is doing something that D can't do itself, or if they're truly an independent contractor, and A maybe we'll come on to. But if they're truly an independent contractor, then as I indicated at the beginning, they got caught by Woodland. Woodland is a case where the school was the defendant, albeit through the local education authority, the county council. The claimant was a pupil. She went to a swimming lesson. The school used to provide swimming lessons themselves, but they'd outsourced it to independent contractors, so there was no vicarious liability because they were an independent company. During the swimming lesson, she drowned. The swimming teacher and lifeguard failed to notice. By the time they pulled her out, she'd suffered hypoxic brain damage. and the claimant alleges, because there wasn't proper insurance for the independent contractor, swim teacher or lifeguard, that the local education authority owes a non-delegable duty. As I say, the defendant applied to strike out, succeeded at first instance and in the Court of Appeal, but not in the Supreme Court, where Lord Sumption rewrote the law on non-delegable duties and identified a five-stage test. I think he refers to them as criteria. First, the claimant's a vulnerable person, so it's a child, a prisoner, or a patient. So it's going to apply to those seeking medical treatment. Second, there's an antecedent relationship which puts the claimant in the defendant's charge or care so that the defendant has control. And I think one needs to think carefully about what that means for a patient. Now, if you are completely incapacitated, it would be self-evident, but anyone who goes into hospital for medical treatment puts themselves under the care, relying on the skill and expertise of the medical professionals, and it's clear that that will be sufficient. How far we can then push that is another matter. That control gives rise to a positive duty to protect. The claimant has no control over how D performs the obligations, and D is delegated to the independent contractor some function which is an integral part of the positive duty assumed towards the claimant. And the independent contractor, importantly, is exercising the defendant's control and custody over C. The negligence isn't collateral, but in the performance of the very function assumed by the defendant and delegated. Well, that all sounds very good, but what does it mean? Use Woodland as an example. Annie Woodland, she's a pupil at school, so she's a child, she's a vulnerable person. She's in the school's care, there's an antecedent relationship because she's a pupil there. And because she's in their care, the school has to protect her. She's sent on a swimming lesson, and so she's got no control over who is teaching her to swim. The defendant delegates to the independent contractors, the swim teacher and lifeguard, the positive duty to look after her. And while they're doing that, they're in control of her. And finally, the negligence is precisely the negligence which, if the school had employed a swimming teacher, they would have been liable for. So applying the five-stage test, there was a non-delegable duty. Now, two issues are going to arise, or maybe three. One is when you've got private medical treatment, quite often, if you're on a Bupa policy, you will choose the surgeon and the hospital. So you might go and see Mr. X in Harley Street who says you need an operation and I work from the Spire or I work for the BMI hospital. And if that's the case, query whether criterion 3, that you don't control how the function is provided, exists. Secondly, does it apply to a deliberate assault? So if you have a doctor who assaults you either on the technical, no consent, or on the obvious and actual assault, is that a breach of a duty to take care? Remember, it's a delegated duty to take care, not only that you take care yourself, but you ensure care is taken. In JB versus Leicestershire, His Honour Judge Godsmark ruled on precisely this point against the local authority.
And
it's one of the issues, and me, and it's one of the issues that the Supreme Court are going to consider next week, because in NA the same issue arose, and Males J, who was the child judge, followed His Honour Judge Godsmark, but Lord Justice Burnett disagreed. So, case study. So we finally get to a case study. So I act for a claimant on a Bupa policy and she's got a lump on her neck. She sees an orthopedic surgeon privately who says, the lump on your neck is a lipoma and I need to excise it in an operation. So she goes into Spire. He is one of Spire's approved consultant surgeons, and we'll come on to that. The operation takes place. He's negligent and cuts the nerve, so she can't. She pays him and Bupa separately. He's not indemnified by the MPS because he's already in trouble with the GMC. And so we can't sue him, or we can, but we mean going after his house, which was highly mortgaged, and I think there may have been other people going after it. So can we make the hospital liable for his negligence on the basis either of vicarious liability or a non-delegable duty? We pleaded against them on both bases, and they settled the claim at full value, although putting in a defence, interestingly, by one Philip Turton, who was, in these cases we're referring to in Leicestershire, they paid up in full. Now, under the Health and Social Care Act 2008 Regulated Activities Regulation 2010, replaced by 2014, hospitals are required to regulate the activities that go on within them, including private hospitals. And those obligations include making sure that the care that is provided is appropriate. Now, you need to look at the regulations. It seems to me it's arguable that it's a duty to make sure that the surgeon is competent rather than the duty to make sure that what he does is competent. And you can see there's an important distinction between the two. But nonetheless, in my view, if you look at the regulations, particularly the 2014 ones, which would replace the 2010, there is now a duty to ensure that proper care is given in your hospital. Now, that's a statutory duty, but we know that common law doesn't necessarily mirror, but can be, it's the framework. So the BMI have what's called a practices and privilege policy, which sets out pretty much what the regulations require, and the surgeons have to sign up to it. So they are taking an active role in regulating the surgeons. And of course, if you've got an operating theatre and you've got a surgeon, without a surgeon, you're not going to get any money from it. So the private hospitals depend on the surgeons bringing patients in to perform the operations. And in that way, if we go back to the test for vicarious liability, it's arguable that there's integration into the business activity of the private hospital, the role of the private surgeon. And certainly that's what was pleaded. And if we apply the Crocs criteria, the defendant's business interests were involved and furthered by the surgeon. They derived profit from surgery conducted in operation theatres. They authorised the surgeon to undertake the activity, surgery in the theatre, and that activity, surgery in the theatre that they owned, gave rise to the risk which materialised the negligent operation which cut the nerve. And if you think about Lord Reed's concern about the delivery of services in a modern economy, it follows and applies to that. What about a non-delegable duty? Patients in a hospital, so that's stage one. The hospital has the positive duty to the claimant to treat her. 3 is difficult because she's got the surgeon in herself, but of course, because the hospital has to have a surgeon who they've authorised, it's arguable that the pool of surgeons that she can have to operate at that hospital is limited, and so they are exercising control as well. And if you assume that the hospital has a duty of care to treat, they have delegated to the surgeon precisely the duty owed to the scene, which is that she's treated with, to the claimant with appropriate care. And of course, if the operation is negligent, it's not collateral but central to the care being provided. Which brings us on to NA. This is foster parents, and it deals with both concepts. And so when the Supreme Court give their decision, which I suspect will be in July, it will at least clarify the interrelationship between vicarious liability and non-delegable duties, and I hope give us some further guidance on how the criteria should be applied in both. The claimant was placed in a foster home by the local authority, Mrs. A, and then Mr. and Mrs. B. She alleged physical abuse against A and sexual abuse against B. The social workers weren't negligent in any way, so there was no direct negligence. So instead she went for no fault, vicarious or non-delegable. Trial judge, Mr. Justice Males, the abuse occurred, social workers weren't negligent, no vicarious liability for foster parents. They did owe a non-delegable duty of care, but it wasn't fair, just and reasonable to impose it. And so he says no vicarious liability because there's no control. At that point, Cox hadn't come out, which is an important point for the appeal. It wasn't even available to the Court of Appeal. Tomlinson finds again that because social worker, foster parents are providing family life, and the local authority can't control how family life is being provided, there's no control. So, query, are they then independent contractors? Tomlinson also found that the fourth stage of the non-delegable test wasn't satisfied because providing a family wasn't something the local authority could itself do. Burnett, as I say, said you didn't breach a non-delegable duty to take care by an assault because it would change the nature of the duty, i.e. an assault is a deliberate act, not a negligent act. The duty to take care is breached by negligence, and therefore a deliberate act can't breach it. If you say that the injury itself breaches the negligent act, then in effect, so breaches the duty to take care, then you are creating strict liability because the duty of care is breached by injury however caused. And finally, vicarious liability deals with assaults. And I'm just rehearsing. So we're going to have the two sorted out this month in argument and July. One other wrinkle for non-delegable duties going forward is Farage, which was considered prior to Woodland, but which Sumption approved. And very simply, King's sent some fetal matter to be tested to see if there was a genetic disability. And the lab that did the test made a mess of it, came back and said there wasn't. In fact, there was. And they then sued King's and the independent laboratory. The laboratory were liable. King's was not. They weren't liable because the testing wasn't something they themselves did. And they didn't have any control or custody of the patient. Now, if we think about much treatment, it doesn't involve custody and control of a patient in a traditional way. So obviously if you go in on a gurney or you're taken by ambulance to hospital, there's custody and control. But what about the lady, the example I gave, who went for scans? She never goes into hospital at all. She goes to one person to get the scan, and the scans themselves are then sent to an independent contractor to look at. So does that constitute custody and control for Lord Sumption's test in Woodland? Applying Farage, you'd think it might not be. And you can see lots of other x-rays, sending out for blood samples, DNA testing, even outpatient treatment. There might be an argument absent custody and control. I suspect that misunderstands what Lord Sumption is saying, because what he's saying is that it's the custody and control in respect of which the negligence occurs is important. So if we look at criteria 4, the defendant has delegated to a third party some function which is an integral part of the positive duty which is assumed towards the claimant, and the third party is exercising for the purposes of the function thus delegated to him the defendant's custody or care of the claimant and the element of control that goes with it. So if you take a scan, even though you don't control their body, they are entirely reliant on you to properly interpret that scan. And of course, if the scan had been taken and read by the hospital and they got them wrong, there'd be no doubt that that was a breach of their duty of care. So the fact that they arrange an independent contractor to take on that element of control, in my view, shouldn't mean that because there's not physical control, there's not a non-delegable duty. And I would rely on Baroness Hale, who says that the common law is dynamic and it develops and adapts to meet new situations as they arise. Well, in Woodland there was obvious custody control, which doesn't rule out the kind I'm talking about. And she says that these 4 criteria should not be treated as if they were statutes and can never be set in stone. So Woodland is the baseline from which we now go on to interpret non-delegable duties in other factual situations. So trying to wrap it up, if you've got cases of private treatment where the treating physician for some reason isn't covered by insurance, has disappeared, using these 2 principles, no fault liability, vicarious liability and non-delegable duty, looking at the way they've been developed in other spheres, that cross-fertilizes into clinical negligence claims. And certainly I am seeing a lot of these cases and pleading them and there will be a lot of argument as we go forward, as we try to expand the boundaries to cover new factual situations. But the whole point, going back to what Lord Cox said, is where you have a breakdown in the traditional provision of services, that the law should catch up. So people shouldn't be left without a remedy just because Andrew Lansley took a hammer to the NHS. Any questions? Stunned silence.
I've got one. Adam, I'm sorry, Mr. Weitzman, Queen's Counsel, as I'm now obliged to call you. Let's mix the abuse and the clinical setting. Take an NHS patient.
Yeah.
For waiting list reasons or whatever, the NHS send that patient out for treatment in the private sector. That patient, during the course of examination in the private sector, is sexually abused by the doctor, sexually assaulted. Is the NHS liable for the sexual assault?
I suspect not. I think it would be a non-delegable duty, and the non-delegable duty is not breached by an assault. But if the private doctor was working in a private hospital, they would be vicariously liable for him, and so the fact that it was an assault, not a negligent act, would be immaterial.
Then why aren't the foster parents liable in NA?
Because they are not proximate to the local authority.
See, we have this battle. I ruled against him on this in my case.
Because the foster parents are quasi-independent contractors rather than quasi-employees, and insofar as a non-delegable duty, if it did exist, it wouldn't be breached by an assault. But the fourth criteria isn't provided because foster parents, and they've existed since 1948, and so it's not a new outsourcing provision, provides something which no local authority can.
There's Court of Appeal authority that says that there's no vicarious liability for foster parents as well, which was part of the problem. The Supreme Court will revisit that, no doubt. We'll continue our battle in the bar, and I should say that Mr. Justice Mayles and I came to different conclusions on this. When it gets to the Supreme Court, between us, there's a bottle of white wine riding on this between Mr. Justice Mayles and myself. If you win, I want the wine off you.
Fair enough.
Ladies and gentlemen, I've had my dig at him. Anybody else want to have a pot?
Did it make sense? Just about. Good. All right. Thank you very much.
Thanks, Adam.
Hello.
Hi, Nigel Godsmark.
Tony Gershlick.
You sit down for a second, I'll introduce you.
Yeah, I need to load up these slides.
Oh, that lady there.
Because she won't know what's what.
Okay.
I'm suggesting these people over here come sit over here.
I think they can all see on the screen behind you. While the slides are being loaded, can I make an observation? Our next speaker is Professor Anthony Gershlick. I think Professor of Interventional Cardiology.
Correct.
At Leicester, and a consultant cardiologist at the Glenfield Hospital. One of the privileges that we have doing medical negligence work is that we get to glimpse the professional lives of others. And we like to think that we gain a little bit of knowledge ourselves with every case that we do. If you're doing birth injury cases, you learn some obstetrics and perhaps some pediatric neurology. If you're doing cardiac cases, you learn some cardiology, some cardiothoracic surgery. And we come away from a case thinking, I'm quite good at this. There's a sort of a smug sense that pervades us until you do the next case. And it's at that point, which is normally a year or so later, that you realize how rapidly medical science advances. And that the piece of knowledge that you had been treasuring for the last 12 months, 2 years, is now completely old hat. Professor Anthony Gershlick is at the forefront of such matters, and he's about to demonstrate how out of date my knowledge is. Professor.
Thank you very much. So you may have noticed me feeling slightly sweaty during those last medical legal cases, although to be fair, I followed to about slide 2, and then it all got a bit mumbo jumbo to me, to be honest. Okay, so thank you very much for the invite. I'm an interventional cardiologist. I'm a practicing clinician. I was up twice in the night with patients on call, so if I don't last the full talk, you'll forgive me. And what I'm going to do is talk to you not about so much the law or all that, but really my aspect is to give you an idea of what happens in clinical cardiology. And you're not meant to go away being as expert as the gentleman on my right, but certainly if you get a flavour and a feeling of what actually happens, then it may be able to help you direct your inquiries elsewhere in the future. So I'm going to talk about modern cardiology and the role of angioplasty, and we'll talk about some cases halfway through and then perhaps at the end as well. So I've pressed this, so I'm not going to do that. So what I'm going to talk about, what is angioplasty? You might think this is a new term, but in fact, it's a very common procedure. I did 4 today on patients, one of which took a very long time and could easily have gone very badly wrong. So clearly things like pediatrics and obstetrics and gynecology are major minefields. But I can tell you angioplasty, when you're trying to get a wire down an 84-year-old's coronary artery and it won't go and a balloon won't go, really focuses the mind. I'm going to talk to you about the role in managing patients, some facts and figures, pitfalls and standards of care, some data sources, and what guides practice. I've got quite a lot of slides, but I'll stop when I get the nod from the gentleman on my right. So, you know, there's all sorts of things about negligence in angioplasty, and although a few of these slides are relatively basic, they do focus my mind, not these slides, but the idea of practicing medicine and cardiology with some sort of medical legal hat on. Not because I want to practice defensive medicine and risk adverse behavior, but because there is no doubt at all that the law looks after the patient. So if I am, for example, I get a letter from a GP asking me about a patient's test or something, and I don't, for example, for very good reasons, in inverted commas, look through all the notes, and then something goes wrong, there are no excuses. And when the situation comes to court, there are no excuses, and the patient is very much put at the center. You get asked the question, why didn't you look through the notes? There are no excuses. So it's very good as a medic, and I teach my juniors, that you should practice medical legal medicine. In other words, if you're about to do a procedure and you think it might go wrong, could go wrong, you've got to say to yourself, why would I do this procedure? Because at the end of the day, the patient has to be at the very center of your practice. So there's lots of areas of cardiology, and what I'm going to talk about is angioplasty. And you're going to see, I don't wear a mask at the top left-hand corner, but I do a lot of the thing at the bottom, your left-hand corner, which is coronary angiography. And that's putting a catheter from the arm or from the leg to take pictures of the blood supply to the heart muscle. It is painless to the patient, but can be very difficult at times. We'll pass the jokes. So the main elements I'm going to talk to you about the patient coronary artery disease, the principle of management, how we make decisions, and I'll give you a legal case example towards the end. So here's a coronary artery, and people who come to me have what's called angina. Angina is the equivalent of having cramp in your legs. In other words, when you run and get cramp in your legs, your demand is outstripping your supply. In a patient with coronary artery disease, their demand's outstripping their supply because they have this narrowing here, this atheromatous narrowing, this yellow stuff. We've got a pointer that works, please. Guys, got a pointer that works? Well, I'm pressing the red button. Oh, it is. It's just, okay. So this bit here is yellow atheroma. That builds up through eating the food we've just eaten outside and not getting any exercise and having high blood pressure and smoking and diabetes. So patients get this build-up of atheroma, and when it gets bad enough, their narrowing of the coronary artery becomes such that when they want to exercise, they can't get enough blood through that little hole down there. Yeah? So, and then they get cramp in the chest, which is angina. And here's some post-mortem samples of that thickening in patients who have angina. So what will they say? They'll say, I start to get chest discomfort with my throat, my jaw on exercise. It settles when I rest, because when they rest, the heart needs not as much blood, and so they can get enough oxygen to their heart muscle. So how may such patients present? Well, they often go to their GP. Unfortunately, too many go to A&E, and some call an ambulance. So the patient issues are, I have to take a history. And in the modern day, histories come in very different ways. Heberden in 1784 described angina brilliantly. You see, it's a choking feeling like being strangled, severe breathlessness that went away when the patient rested. And that's very similar to today. We live in a very multicultural society, and many patients come with very different histories. Some elderly patients come with a bit of breathlessness, a little bit of pain here and there. My job initially is to try and decide whether this is angina or not. If I get it wrong and say it's not angina, they go out and have a heart attack, then that's very important. So we do use our clinical acumen. But we also have evidence of what's called a reversible ischemia. In other words, an evidence that when you stress the heart changes in some way. And when you stop stressing the heart, the original condition returns. And we can do it a number of ways. In the bottom left is an exercise test. We put the patient on a treadmill, they exercise, and we look at their ECG. These are various scans, all of which show that when you stress the patient at the bottom here, then those scans change because of the lack of blood supply, and when the patient rests again during controlled conditions, the scan goes back to normal. This is an ECG. It's very easy for me to look at this ECG because I've been looking for years, but it's no different from me asking you now how to identify a pen or a pencil, and you'd be able to tell the difference. For me, I can tell what this ECG looks like. And if we exercise a patient, you can't see, but I can tell you that this part of the ECG has changed. And when they stop exercising, it goes back to that. So what we're looking at is this little area just here that changes. We get some depression of the segment of the ECG, and the patient gets chest pain and breathlessness, and then we stop the treadmill and it goes back to normal. It's fantastic. I now have an evidence no matter what the patient's symptoms were. If I suspected it was angina, I have evidence that it's ischemia. I'm about to give patients tablets. I'm about to put them on, do an angiogram. I'm about to do all sorts of things which could be detrimental to the patient. So I need objective evidence for ischemia. And this is the sort of test we do. Here's another sort of test, a CT scan. You can see here, just here, that white line, that's the coronary artery. It's very calcified. So lots of calcium. The calcium's associated with atheroma. They'll do a score on that and tell us whether or not that is truly coronary narrowing. But the best of all is the coronary angiogram. This is the cath lab, bottom left-hand panel. And up here, I'm going to teach you all to be cardiologists in about 5 minutes, all right? So every coronary angiogram, see the top left-hand panel, the artery that goes south, up here, yeah? That's the circumflex artery, goes to the back of the heart and it's normal. This is dye being injected through this catheter. It's come up from the arm and you can see it's normal. This middle one, you can start to see, and certainly one on the right, that there's a narrowing there. Can you see that? That the wall is thickened, so the amount of dye that gets through is less. Yeah? Just there. So that patient, it's moving on its own. That patient there with symptom and exercise test has abnormal flow through that. And he explains. So now if I go on and send them for bypass surgery or put a stent in, I can justify when something goes wrong. And all these guys on my right want to ask me a question in court why the patient died. I can say, well, you had an exercise test. It was abnormal, ST segment depression. Patient had chest pain. That was justifiable for doing an angiogram. The angiogram showed a narrowing. I put a stent in. I did it as best I could, according to standards which I'll describe to you. Things don't always go well. They're not like making door handles on cars. These are patients, some of whom vary hugely. And the bottom right-hand panel, you can see with the circle, they're very tight narrowing. And that patient will be stented almost straight away. What's the risk of having an angiogram? About 1 in 1,000 death. So I'll talk to you about informed consent in a bit, but I can tell you we have to tell the patient. Now people talk about the level of risk that we should discuss, and I think people say it's about 1% risk. And we had a long conversation, a big meeting on Tuesday about the new absorbable stents and whether or not we should talk to them about some of the risks. It's about 1 in 1,000 death or stroke or heart attack. There are guidelines out there called appropriateness guidelines. And you can see that if a patient has no symptoms, top right-hand panel, and is low risk, then it may be in red, inappropriate. These are American guidelines, but I have to tell you, UK has taken up some of this. And if I was being taken to court because a patient had died, and these were produced, it would be very hard to justify why I've done the procedure when there are low-risk patients who are asymptomatic. So we do have guidance as to whether or not we should be doing these procedures. And they vary according to the condition, class 1 or 2 angina, low risk, no treatment, inappropriate to continue. So there are guidance out there, but luckily medicine's still about clinical judgment, and that's very important. How do we make our guidelines about what to do? Well, NICE, for example, comes out with these guidelines, says revascularization, bypass graft or angioplasty with stable angina whose symptoms are not satisfactorily controlled with optimal medical therapy. Give them 2 lots of medication, they're still getting angina. I am justified in going and doing an angiogram or doing an angioplasty because the guidelines help us to do that. And it talks here about the multidisciplinary team meeting. This morning at 8 o'clock, we all sat down, surgeons, interventionists, non-interventionists, cardiologists, and we have basically a bit of a bun fight. Someone shows an angiogram, and people say, well, this will do for surgery, this patient should have angioplasty. And the new MDT, so your first question when you see a patient which has gone slightly wrong would be, was the patient discussed at an MDT, multidisciplinary team meeting? They're actually described as being important in terms of guidance. So an MDT is a very important way of doing it. Now, so I'm not going to, that was stable angina. I'm just going to talk about this business. I've been speaking for about 15 minutes, in which time 2 patients in the UK have had a heart attack out of the blue. They went home, they're going to the pub, doing nothing, didn't expect it, but it came on suddenly. And that original pathology I described to you, where atheroma gets worse and worse and worse and worse and gets angina, doesn't explain that, because it's an unpredictable event. And if it's getting worse and worse and worse and worse until they get more and more angina, then that's a predictable event because it's a straight line. So how do we explain the unpredictable nature of acute coronary syndrome? And I was very privileged to know a chap called Michael Davis from George's, who said that when you have atheroma, bottom right-hand corner, you have a plaque event. So you have a bit of a plaque, a bit of a narrowing, it has an event. And the event is either erosion or rupture of that plaque. And I'll show you some in a second. When the plaque ruptures or has erosion, the contents of the plaque are exposed to the flowing blood. Now the body is incredibly stupid. The contents of that plaque are very similar to the contents of the blood vessel wall. So for those of us that shaved this morning, if we nicked ourselves shaving, the fact we didn't bleed to death was because the vessel wall contents were exposed to the flowing blood and we got clot. So we got a bit of clot on our face, which we got off. The plaque contents look like the vessel wall. So when the plaque contents are exposed to the flowing blood, the body thinks there's a breach in the vessel wall. Therefore, we must clot. And of course, the clot forms inside the artery and blocks it. So the reason people are suddenly dropping dead and other ones just had a heart attack as I've been speaking is because they've had a plaque event. And that plaque event has led to occlusion of the coronary artery. And here are some pathology samples. The top is of the narrowing. And here you see at the bottom, on the left here, there's a plaque event, that black bit just here. Yeah, is a plaque event. And here's a plaque event, and here's a plaque event. You can see the plaque is disrupted. Do you see that? And what's happened is the body's thought there's disruption of the vessel wall and it's formed clot. And that clot can either just be part of the vessel wall, can give a small heart attack, or can block the artery completely, and that's a full-blown heart attack. The mortality, 40% of people die before help arrives if that happens. So it's a very serious and significant condition. Luckily, we can tell from the ECG which of this it is. If it's an end-STEMI, don't worry about the term, a small heart attack, the ECG looks a particular way, and if it's a complete blockage, left here, it looks like something else. You're already experts on ECG, so you'd have recognized this already. Yeah? These are different. This is different from this because this is different from this. This is only half blocked the artery and gives you that form of ECG. This is fully blocked the artery and gives you that form of ECG. So perfect, because the ambulance men can measure this, can see this on an ECG. So I get a call at, I can't remember, about 1:30 this morning, say there's a STEMI on the way, STEMI alert. Ambulance man's been called to an 84-year-old lady who's got up to go to the toilet, has got chest pain, collapsed. Ambulance are called. They look at the ECG. They see ST, that segment of the ECG, ST segment elevation, STEMI, ST segment elevation MI, myocardial infarction. Ambulance men look at it. They say, that's fine. We take them straight to Glenfield, forget all the other hospitals, bypass everyone else, get them to hospital because it needs unblocking now. Because time is muscle. Within 40 minutes, the heart muscle becomes irreparably damaged. So time is muscle. There's an occluded artery and there's the atheroma. Here's a good example of a plaque event in real life. This is an angiogram. You know it's an angiogram now. You can see here perhaps that this dark circle is where the plaque contents used to be. Yeah? What's happened is the plaque contents have left because there's been a breach here in the plaque. Dye's got in here, and this is a plaque event. Yeah? Luckily, this patient's artery didn't occlude. So here's the ECG, normal ECG, and there's an ECG with an end STEMI. That's the shape of the ECG. This is a normal ECG here, and this bit of this ECG here shows ST segment depression. This is an end STEMI, a bit of a heart attack. Still needs to come to the hospital, still needs medication, still needs an angiogram, but is not an absolute emergency. This is a 43-year-old lady, sudden onset chest pain, history of arthritis, smoker, hypertension, positive family history. That's her ECG. it's very abnormal. It's got this deep T-wave inversion here and here. I told you you'd all be experts. Yeah? It's really, really, really didactic. 53-year-old man, you could diagnose now, 6 hours onset chest pain, ECG changes, T-wave inversion, N-STEMI, not a STEMI. And the reason that I said is because all this clot occurs in these coronary arteries. This is a longitudinal section here now. Unfortunately, clearly the patient didn't survive, not one of mine, I hasten to add, and has got all this clot that blocks the flow going through from left to right. So there are guidelines on how we manage these patients. It's not just ad hoc, and we have protocols. So the next thing you ask when something's gone wrong, so I'm involved, which is luckily a really big case in Australia, which I've just heard is just settled, which is good and bad. Good that I don't have to fly out to Australia. It's quite interesting. It's a very closed society, and they couldn't get anyone, any cardiologist in Australia to produce a report against what was a really poor case. Any cardiologist. So they flew over to see me, and it was really, really, really what I regard as a poor case. I mean, it was open and shut, and there was the usual, more about this than I do, and there was the usual discussions about what should happen, what should be paid, and I'd had my flight booked and everything, and then it was suddenly settled. And that's because the people did not treat the patient according to the guidelines. The guidelines are you treat the clot, you do the angiogram. They didn't treat the clot properly. They did the angiogram. She had clot that went down another vessel. She arrested, had a cardiac arrest, cardiac massage, eventually got to theatre, and is left with hypoxic brain injury. Now, there are all sort of things that were happening about, whose responsibility it was, the hospital trust. But one of the things that I brought up was that protocols are critical. Do the hospital have a protocol for how this patient should be managed? The answer was no. Who was responsible for the patient? Was it the cardiologist who admitted it, or was it the guy who did the angioplasty? Eventually, they were sort of throwing things at each other. But it was quite clear that this was a poorly managed patient because they didn't follow the guidelines. And these guidelines, you don't have to go through this, but they're quite clear, you see. What they do is they talk about class 1, 2, 2A, 2B, and class 3, and then level of evidence. I've done one of these. So I got asked to be on the European STEMI guidelines in 2012. And I didn't know what it was about. The ESC asked me to be involved in this. They put me on a plane, took me to the middle of France on a Friday afternoon. The food was a lot better than the wine was a lot better than outside. It was fantastic. Oh, this is great. Lovely chalet. And at 6 o'clock, we arrived about 6 o'clock, we sat down, about 20 of us, and they gave us 650 papers to review over the next 2 days. So these guidelines are very important. And class 1A means it's highly recommended by us. Take the top one. 1, this is what the people in Australia didn't give this prasugrel. 1A means that you should give it, that's what we recommend, but it's only B, and B is the level of evidence. 1A is a randomized trial. Give them one thing or the other. When you give them one thing, they do better than the other. Class B is different sorts of studies, registry studies, and Class C is expert consensus. So if ever you get a case, you should look up what the guidelines are. You should say, you can look these up. You can say, this is class, okay, wait a minute, they gave the patient this drug and it's only class 2BC. What on earth is that about? Or it was class 1A, according to the European guidelines or NICE guidelines, therefore it was the right thing to do. So here, prasugrel, top, is an antiplatelet agent. Class 1, we all believe it's really important, but the evidence isn't so strong, but we still think it's important. Class go 2 down to bivalirudin 1A, the data to support that recommendation of it should be given is really strong. So that's the guidelines. And here you see use of ticagrelor as part of therapy is not, triple therapy is not recommended. Don't worry what that means, but it's 3C. So if you see a 3C, that means it does harm. I was privileged to be part of a trial that was a UK trial that changed the American guidelines from doing 3C to 2AB. So they depend on randomized trial. And there are lots of them. This is go to the ESC webpage. You can look up whatever you want to look up. You know, here they all are. Whatever your case you have in front of you, just dial into the ESC guidelines, have a read of them, see what happened fitted with what was recommended. That's what the physician is meant to be running their practice by. So that's what you need to judge them by. And there are others as well. So that's my recommendation. What about consent? You know perhaps a bit more about consent from the legal perspective. We are obliged to get informed consent. What does informed consent mean? Sometimes it's very difficult to understand what the bit informed means. Sometimes people don't understand. Sometimes people don't. First language isn't English. Maybe they're elderly. Maybe they're deaf. You know, there are all sorts of issues. And sometimes I walk away and I go back and think, I need to just explain this a bit better. I'm not sure the patient was fully informed about what I'm going to do. So informed consent is a really important issue. And in informed consent, you have to, don't get like the American system where they're given 30 pages of information they're expected to read. But certainly you need to check about informed consent. So we were involved in a legal case where a junior doctor didn't give one of those drugs. And it's a very, very emotional case. I went to the coroner's court. And I'd done a very complex angioplasty at the left main stem, the very origin of the arteries. And this new junior doctor, Monday morning, didn't have the notes, didn't know what this drug was. Patient had a bruise, which these drugs can cause. He knew that. And he stopped the drug. And 8 days later, the patient was readmitted with clot on that stent because he'd stopped the drug, and the patient died. And we went to coroner's court. It's a very, very cathartic moment because his mother was there and the man's partner was there, and they were sitting in the back. And this idea that there is no excuse came very much to the fore. Why didn't he find the notes? Why didn't he ask a senior? Why did you just stop it? Why? All those sorts of things. But of course, there's a system, there's a process, and it's always the system can be seen as at fault as well. So the hospital should have provided, made sure the notes were available, should have all that. But it was very, very important because I was asked, I took the stand and was asked about the consent, and I'd drawn pictures for the patient on the notes. I'd written in the notes and drawn pictures. And that was really important because it told the coroner that I had explained and got the patient's informed consent. So when you see any of these cases, you have to know whether or not there's been informed consent. This case was going on and on and on. It's an incredibly emotional, cathartic session. It's really going on. The young doctor said, stop, stop, stop. Stop, I want to stop. And he said, I made a mistake. I should never have stopped the drug. And that was it, you know. In the end, it was ended up with the mother and the partner hugging each other. It was a very cathartic and emotional time. Informed consent is very important. So this is NICE guidance and GMC guidance, and you need to look at that and understand what's involved when a doctor goes to a patient and asks them to have a procedure, suggest to have a procedure. And there are pathways which I won't go into because I haven't got time. So here's your end STEMI patient, and we've done an angiogram, and there, look, there's a narrowing. You all see that? Only because the green arrow, I bet. But even if it wasn't a green arrow, you'd see that that was a narrowing. That patient's trying to have a heart attack. They're trying to block that artery. So that patient, so the other case I'm involved in, which is still ongoing, is in a region somewhere outside London, where a patient comes in and he's got chest pain. And if you have chest pain, he's high-risk patients, hypertensive, diabetic, smoker. He's a male. He's not an 18-year-old girl who can have chest pain. It's almost very unlikely to be coronary artery disease. So he's got all of these things, and they do one ECG, and they do one troponin. Now, when you have a narrowing like this and an N-STEMI is also diagnosed by a troponin rise. A troponin is an enzyme that's released from downstream heart muscle cells. It's a really good test for an N-STEMI. Man goes in, a little bit of ECG changes, chest pain, but they do one ECG, which is sort of within normal limits, and one troponin, which is normal. And then they send him out, seen by a consultant. Junior doctor says, I really think this is cardiac. And he's walking his dog, he gets chest pain, he stops walking his dog, and the pain goes away. They send him out, he reappears as an emergency with a blocked artery 8 hours later. And the bantering that's going on, and survived, but the bantering that's going on between myself and the defense expert witness is about the timing of the troponin, whether it was 8 hours or 10 hours. Those sort of semantics are really not so important. But in this case, patient comes in, ECG changes, we do an angiogram, needs treating. Yeah. Here's another case. Sorry to all this. You can see where if you have a little test. Tell me when to stop when it's significant. Oh, there, right, okay. So that's a significant narrowing in the right coronary artery. And here's a patient with lots of narrowings. 1, 2, 3, 4, 5. You see all those narrowings pointed out. That patient's much more likely to go for bypass surgery, where they take veins from the legs and bypass those narrowings. There are about 5 or 6 times many patients have angioplasty as bypass surgery nowadays, and it's almost up. Let me just relatively quickly take you through two more things. One is balloon angioplasty and stenting. And at the bottom right-hand panel, the top is my cartoon, top right-hand panel, you go through the atheroma, you blow a balloon up, I'm doing it today, with an indiflator. I did my first angioplasty about mid-80s or early 90s. And blow a balloon up, and there's to take the balloon down, you've got rid of some of the narrowing, yeah? The bottom right hand, we fill the balloon with dye, yeah? So we can see where the balloon is. So that balloon's been blown up in an artery, this one at the bottom here. Of course, all sorts of things can happen. The artery can rupture, the artery can close. There's all sorts of things. One of the things about the angioplasty, you'll see here there's a wire. There's a wire goes through the narrowing first of all, yeah? You can't quite see it, but the balloon runs along the wire. So one of the things about the Australian case was the procedure was terrible. It was really poor. They lost wire position halfway through. When things start to go bad in the cath lab, there's a great tendency for everyone to get very excited. And people get very anxious and start calling for the surgeon, calling for a balloon pump, calling for the water board, gas board. They call for everyone they can think of calling. The trick is to really remain calm and make sure you keep your wire position, because if you lose your wire position, the artery can close and then you can't get a wire back down. The patient has a heart attack and dies. During that case, they lost wire position halfway through. Well, that's a disaster, because the vessel's now closed and you can't get the wire back. The thing about balloon angioplasty is that you blow the balloon up. When you blow it down, you can cause narrowing, worse narrowing, because you've injured the artery, and that could be like a plaque event. It can block. So stents have changed all that. These are fantastic devices. Every single stent's the same. If I want a 2.75 by 12 millimeter stent, which is what I put in today in this lady, that's what I get. It's mounted on a balloon. We deliver it on the balloon, blow the balloon up, take the balloon down, and leave the stent behind. It scaffolds. So it's a bit like, if you think of a corridor, the wallpaper coming off the wall after the balloon angioplasty, perhaps blocking the corridor. Here you've got a stent that scaffolds the artery. Here's an example of a ballooned artery in the top left-hand corner, and here's an intravascular ultrasound showing the stent struts which have kept the artery open. So one of the questions you ask, if some of you have an angioplasty type case, is did they have a stent? What sort of stent was it? And all that, because this is standard of care. There are millions of stents out there. This is just an old figure, about 200 Me-Too stents, most from India and China, but there are about 5 or 6 standard stents. And this is what we do. We showed you this earlier on. So here's a live case. Yeah, you're all experts now. That's the right coronary artery, looks pretty normal. Yeah, top. That's pretty normal. It's injecting, this dye is being injected via this catheter through here. There's a bit of narrowing there, a bit of narrowing there, agreed? A bit there and a bit there. And if we go to the left system, that's the right coronary artery because it's the patient as they face you. If we look at the left system, the most important thing you can see is this narrowing just here. Yeah, in the circumflex, just here. So I'll run it again. So if you keep your eye on that, it's difficult because there's different frames. If you keep your eye on that bit, you'll see that, you see that? So that bit there in the circumflex is very tight. Yeah. So that needs stenting. There's a wire that's gone through. Can you see the wire? And here's the balloon on the right. And on the right here is the stent that's being placed. Maybe you can't see it, but okay. So let me just here is the stent. 2 dots, metal on a balloon. Yeah? Very low profile so we can deliver it. So here's the stent, here's the wire through the narrowing. 2 dots of the stent on a balloon. Very low profile. Put dye in. Once you've blown it up, you can't take it down. So I spend ages and ages. I have juniors who can never position to go like that, like that, like that, like that, like that, like that. Getting closer and closer. Sometimes I say, if you hold the balloon still, we'll move the patient for you. Once you've blown this up, you can't take it down. And here's it afterwards, the stent blown up. Yeah, just here. And then we put another stent in the top end. So that patient now no longer has angina and has non-acute coronary syndrome, and it is a lot better. Yeah, but a lot of things can go wrong. You know, the wire can come out, all sorts of stuff. And that's the result. Yeah, you can see here that the artery just looks really fantastic. So when they used to have angina and had to stop, this patient was a very interesting patient. I used to say he was very grateful because he used to go to the village and he used to have to stop at the wedding dress shop. And people used to wonder why he was stopping at the wedding dress shop every time. It's because he was getting angina and he couldn't get past the wedding dress shop. Now he's able to walk past the wedding dress shop, which pleases him hugely, because he now has really good flow in that circumflex artery. Finally, I'm just going to talk about STEMI because these are what we did last night and what we're on call for all the time. And we've talked on the left here about plaque erosion and plaque fissure. We talked about thrombus. Well, these patients need to be treated, the ones in the middle with the slight blank here, the blackout here, need to be treated within 72 hours. They should be settled on medical treatment. If they're end STEMI with that T-wave inversion that we saw, they need to be treated within 72 hours. STEMIs, time is muscle. Yeah? Cells are starting to die because the block, it's not like your grass hasn't been rained on for a while and eventually it dies. Once you get blockage for long enough, and it's usually about 6 to 12 hours, the scar tissue forms the muscle, and there's no point in opening the artery. Yeah, because it's a bit like watering your grass that is dead. So these are real emergencies, and because it's a STEMI, the ambulance crew phone in, they say, we think we've got a STEMI, expected time 20 minutes. They phone me or whoever's on, and everyone drives in, rushes in, hopes they don't get caught on the speed cameras. You know these ECGs now. Top is a normal ECG, yeah? Up here. Here this ST segment that had T-wave inversion for is now elevated. Yeah? This is ST segment elevation myocardial infarction. Even you who've never seen these before could tell the difference between those two. Yeah? I can promise you that's the best thing about this is that ambulance crews can do it as well. So they look at it in the ambulance, patient with chest pain, sweaty and feeling sick, and say, this is a STEMI. We can phone it as a STEMI. Bypass Nottingham City Hospital or wherever, or hospital, and go straight to Glenfield, my hospital, where we have people ready to go. Forget. So that's what it looks like. It used to be thrombolysis, giving clot, busting drugs. It changed dramatically. I was part of the NIAP team in 2008 that promoted primary angioplasty, getting to the lab, poking a wire through. Wires go through very easily, sucking out some clot, putting a stent in, compared to giving them clot-busting drugs, the red line. And you can see that in about 2008, 2009, as a result of that government Department of Health-led initiative, angioplasty took off. And we've done well. If you just look at here, these figures at the bottom here, these are all the centres in the UK that are talking about who are giving angioplasty. And it's now gone up from, I think it was 0.3% to 83% in 10 years. It's the standard of care. If you have a patient who comes in, has heart attack, goes to the lab and hasn't had primary angioplasty, you want to know why? Because it's standard of care. This is the guidelines that I was on, ESC guidelines for the management of acute myocardial infarction presenting with ST segment elevation. And we looked at 650 papers. And again, we gave recommendations, relief of pain, breathlessness and anxiety, you see here, so we're pretty holistic. And pre-hospital care, pathways about what to do with the patient depending on how they present, and all of these guidelines. So here's a patient. Yeah, we always look at the non-heart attack artery first. So this is patient comes in with ECG change in a certain place that tells me it's the right coronary artery. So we always look at the left coronary artery first. Here's the left coronary artery. There's a bit of a narrowing there. It used to be 3C in the American guidelines that you shouldn't do that. You shouldn't do that artery at any time. I did a randomized trial where I randomized patients to just having the blocked artery or to having the blocked artery and the narrowed artery. And we showed that patients who had the narrowed artery done as well as the blocked artery did significantly better. So we changed the guidelines, the American guidelines. So we've seen this. We always look at the non-infarct related artery first of all. So here's the right coronary artery. And you can see, unlike before, it stops there. Yeah? So the blood comes down, or dye in this case, and stops at that point. That's why, that's the clot. The plaque events happened here. Yeah? The plaque events happened here. Clots formed, it's blocked the artery. The muscle was dying at that point. And the right thing to do is to get a wire through, balloon it and stent it. Because suddenly they'll be better, the ECG will come down and it saves their lives. So this is standard of care. So, Chairman, tell me how long you think this artery is. That's you.
How long I think it is?
Yeah, so where will it go? You don't know. About there.
Yeah.
It's a very, very, very big artery. So this is before we do anything. Yeah, and there's no blood beyond this bit here. Yeah, you can actually see filling defects, see bits of clot in there. So this is the wire, and that's afterwards.
Yeah.
Yeah, so that artery, you can still see the wire we've just taken up. That artery was huge. We put a stent in here, yeah, where it was blocked. And now the blood flow goes all the way down. All of this heart muscle was in danger, and that patient would have died. So if a patient presents to you the case hasn't had primary angioplasty, you want to know why. Final couple of slides, just to get it in context. This is the a number of angioplasties in the UK in 2014. Every single angioplasty in the UK has to go in front of the BSIS group. Every single case. 96,000 angioplasties, and look at this at the bottom, 17,000 bypass grafts, yeah? So it's about 5 or 6 to 1 patients having angioplasty versus bypass grafting. I was talking the other day to someone about how I got booed off the stage in the 1990s by the surgeons who thought what I was doing was dangerous and irrational and not right for patients. And we stuck with it and produced evidence, and now it is the dominant therapy. Of course, we haven't taken over, and it just goes to the last slide. We haven't taken over because if we'd have taken over surgery, the drop in there would be equivalent to the increase in PCI. But of course, this curve is much steeper, and that is all to do with the acute coronary syndrome, the end-STEMIs and the STEMIs. And surgeons won't take any patient with a heart attack, big or small theatre, because patients do really badly with bypass surgery. As you saw, the last patient did really well. So that's BSIS. I'm not going to go through all this because there's no time. And the other, just the final thing, saying most people do radials, and that's because you get incredible bruising in the femoral. Just before I came, a really obese man, need an operation tomorrow, need an angiogram, so obviously I go radial. So a case, if a patient has a complication from a procedure, you have to understand what the guidelines say about how it should have been treated. Let me just show you the last thing, if I may, and that's us. And you can look me up. Every single cardiologist is now has in the public portal. It was coming our way, partly because of Bristol. Lots of things happened since Bristol that really focused their attention on medics, particularly the surgeons. Many surgeons now feel less inclined to do complex cases and give them to me. This has been with us in the last 2 or 3 years, and you can dial in the person who you're either representing or not representing and find out how many angioplasties they've done and what their outcomes are. I think it's probably a good thing. I think it causes, my worry is it causes risk adverse behavior. Yeah, patient comes in, cardiogenic shock, not so well, probably going to die. So I was in the other night, last week, Tuesday night, a patient who was on methadone, drug addict, came in and was really sick. A young chap of 42, really unwell, a bit cachectic, loss of weight, and looked really a bit terrible. And blood pressure was about 80 as opposed to 120, 130, and really looked as though he wasn't going to do. And, I'd say, let's take him up to the cath lab. I think he's having a heart attack. Unfortunately, we didn't get him onto the cath lab table because he arrested and died before we got him onto the table. But you could imagine that risk adverse behavior could come into play. I want to do my work. It's okay for me because I'm quite a long way on in my career, and I will take on high-risk cases, not arrogantly, but because no one else will do that. But you could imagine if you were starting off your career and you had a high-risk case, you only have to have one death and you have to do another 99 live patients to have a 1% mortality. And I think there is a danger that this leads to risk adverse behavior. There's a wonderful thing when this was coming out on Radio 4 when somebody said, if I get on a plane, I don't expect to know how many near misses the pilots had. I expect BA to have sorted that out beforehand. We talked before about the relatively incompetent surgeon who took someone's nerve. I mean, that has to be sorted out by the process. So whether this is good or bad, I'd be interested to know what people think. Can be debated. But you can put me in, here I am. You search for PCI operator, search for hospital, and you can do this now. This is me, my GMC number, total number of PCI procedures, 644 in 3 years. The minimum number is meant to be 75. So I'm well ahead of that game. Tells you how many I've done. 37, one. This is 2014. So you can tell how many procedures I've done. You can tell what sort of procedures I'm doing. In blue is stable. In yellow is end STEMI. In purple is primary PCI, the case you just saw. That would have been one of these cases. Shock, which has a high mortality. And so you can see my case mix. See what I'm doing, getting good results. I'm doing very stable patients, or whether I'm getting bad results because I'm getting unstable patients. You can see radial access. I do slightly less radial access. I do 66% as opposed to 75 because I do a high risk case and someone has to go via the groin, been treated before. He says making excuses already. You can see there's very little missing data. At the bottom, missing data is a really important issue. You can see where I lie slightly above the average, which is the black in terms of MACE free. So 98-point-something% of my patients are MACE, major adverse cardiac event free. Yeah, and you can see, compare with the national average. They do funnel plot curves. If you're 2 standard deviations outside, you get spoken to. And this is my survival at 30 days. And it's all sorts of breakdown diabetes. There's one surgeon who's very much against this, and this is his last slide. This is my last slide. It's changed the focus from patient care to self-preservation. I think this is probably not true. I don't think we have any choice. Risk-averse practice and lack of empathy or stress response is not voluntary behaviour. Surgical training has deteriorated. Negative impact on recruitment, UK graduates. Professional integrity has suffered overall. That's from Stephen Westerby, who's a surgeon, very good surgeon in Cambridge. I'm going to stop there because I hope that I've given you a flavour of what we do, of the risks that we take on behalf of our patients, and how there has to be a degree of trust because patients don't understand anything to the degree that they should do, but it's just sometimes not possible to get information across. I hope I never see any of you, particularly not you, on the wrong side.
Is there any part of surgeon-specific data which indicates how complex the procedures are?
Yeah, it's a really good point. So one of the things that I've always spoken to is risk-adjusted.
Yeah.
And risk-adjusted behaviour is really important. So Magda Yakub, who I worked with for a long time, 40% of his patients have already had a scar on their chest. So I think risk adjustment. So if I take on high-risk cases, you know, I have bad results and I have a court case that comes against me and I get suspended, then I'm taken out of the system. Now, the system's not good enough to fully adjust for the risk of that patient, not least because they don't include surgical turndown. So there are lots of patients, an MDT patient today. There was one patient presented by a surgeon as a man with obstructive airways disease. He felt the anaesthetist, the anaesthetic would be high risk complex angioplasty, had been referred for surgery because it was one of the ones with lots of narrowings. He says, I don't want to do it. So I said, I'll see the patient clinic on Tuesday. Point is that that doesn't get put into the formula. So the answer to your question is yes, but not enough.
Yeah.
I'm done. You all look exhausted. I was up twice in the night. What's the matter with you?
Any questions for Professor Gershlick?
Stunned.
That's what I mean by a privilege to look into somebody else's professional life. Professor, thank you very much indeed.
Pleasure.
There may be some wine outside. Thank you all very much indeed. Thank you for attending. Hope to see you again soon.
If anyone wants to come and chat whilst I'm going, you're not going to come and chat. Anyone who's got chest pain, see me later. See me later because I'm on time and a half.
I just had a couple of questions from the webinar. Would you mind
From
speaking
questions,
to
yeah?
the microphone and answering them? They're just
Where are the
on
questions?
there for you, sorry. Third question.
Oh, these are from somebody else?
Yeah, they're from people watching over.
Oh, hello?
They should be able to hear you.
Okay, so the first, oh, she's left.
No, sorry, Nick Haley, what is the current thinking on use
Okay,
of
what is current thinking of the use of thrombosuction catheter? Am I right in thinking there's some debate? Yeah, Nick, can you hear me? Yes, you can. Yes, you're right. So I was part of the total trial, which is a huge North American trial of 10,000 patients that randomized patients with the clot in their artery, like that right coronary artery I showed you. We randomized them to routine suction catheter to suck out some of the clot, or just angioplasty, and we showed no significant difference. So routine thrombectomy is not recommended, and the guidelines have changed. So that's a great question. Patient with A&E with myocardial infarction, 24 hours onset ECGs shows STEMI. No, the answer is probably not. 24 hours is probably, it just depends. These are very difficult cases because they clearly have had a blocked artery, but they're on the borderline of the efficacy of doing something. So it depends. If the patient still has chest pain, then I probably would take them to the lab. But there are guidelines from a trial called the OAT trial that suggests that you don't do them any good. Certainly if they get to 72 hours, you probably do them harm. So, 24 hours I think is a sort of a debatable time. I'd see the patient if they still had pain. If I felt that I needed to know they were a young patient, I'd probably take them to the cath lab anyway, but I wouldn't feel obliged to unblock the artery. Good question. What, any others? I don't. Is that it? Okay, bye-bye, whoever you are and wherever you are.